all the faculties and delegates to the critical review of ESMO 2025 in breast cancer treatment approach. We thank you everyone for joining us this evening for a scientific journey through the most impactful update of ESMO in this year. It is our privilege to have highly respected oncology experts with us today. Now, I would like to invite our esteemed chairperson, Dr. P.N. Mohapatra, sir, for opening and introduction remarks. He is a director in the Department of Medical Oncology at Apollo Cancer Center, Kolkata. Over to you, sir. Sir, we are not able to hear you.
Can you share that one slide? Actually, I have to tell
Yes, sir.
that slide. Okay, thank you actually for Astra for inviting actually. Every year, actually, ASCO ESMO teaches such lot of things actually. And this year, actually, it is same and lot of trials came. This is actually the breast cancer trials actually. So if you see the when it is three type of trials actually. One is in hormone positive, one in HR positive, one in triple negative actually. This is actually interesting reality one. This is actually if you give somebody actually AI um, with CDK4/6 inhibitors, and they start developing ESR1 mutation actually. And here actually you give the new drug actually the estrogen receptor degrader actually the camizestrant actually this is the drug, and you actually then you continue with the CDK4/6 inhibitors. The CDK4/6 inhibitors may be anything actually. It is palbociclib, ribociclib, or abemaciclib, and you will get a good result actually. As per this trial, you can get a good result. So if you come to uh, the hello, if you come to the actually the HER2 trials actually, this was the Destiny West 11 actually. A lot of new trials came actually. This is actually if somebody is a high risk early breast cancer, whether you will give the standard of therapy or TDXT only or TDXT and THP. When THP is trastuzumab, pertuzumab with chemotherapy actually. So as per the trial actually, if somebody is high risk, 4 cycle TDXT and 4 cycle of THP is better than standard chemotherapy actually. We'll hear more from this actually. This is actually putting trastuzumab deruxtecan ahead of what the indication are actually, and this is Destiny 05 actually. We are treating patient with actually pertuzumab, trastuzumab with chemotherapy, and if somebody has a residual disease, the standard was actually TDM1. Now actually this is the TDXT versus TDM1 actually, and as in the all the trials, TDXT has shown a better actually the result actually. This is Destiny Breast 09 actually, and this is but in the metastatic setting, putting again the standard Cleopatra regimen. This is TDXT plus pertuzumab or pertuzumab, docetaxel and trastuzumab actually, and it's actually the TDXT pertuzumab is better actually, and which may be may not be practice changing. We don't know. These are the trial actually. These are not the approved indication till now. And this actually neoadjuvant actually extend trial. Neoadjuvant actually we are giving trastuzumab, pertuzumab with chemotherapy. This is again TDXT versus standard of care chemotherapy. Then there was some hard to low presentation actually, and one is Reality 01. This is a phase 4 trial actually to see the hard deruxtecan, the indication and safety actually. And actually TNBC, this is the Tropian trial. This is datopatamab deruxtecan and versus chemotherapy. Who are actually, if you see the TNBC population, you need PDL1 up to 10% actually in the metastatic setting. And some patients are not eligible for immunotherapy. These are the not eligible patient for immunotherapy, and dato-DXT is performing very well, which will be we hear actually. This is actually again a neoadjuvant durvalumab trial actually, and here actually if you see the PCR rates are equal actually, but if you see the um, event-free survival, overall survival, durvalumab actually long term is better actually. And there is some dato-DXT durvalumab clinical trials actually, and I will not go much and will hear actually now the when I go to the speakers, Dr. Ajay, he will be speaking on Destiny Breast 11, Dr. Destiny 05, and Dr. Devaja.
Very good evening, everyone. Thank you, Dr. Mahapatra, for taking the initiative to start off this series on ESMO breast cancer latest updates. Am I audible?
Yes, sir. Put it full screen, sir.
Yeah, just a second.
Yes.
Fine.
Yes.
Okay. So this is moving on and straight away diving into the agenda of the evening. I'm going to speak about the latest of the DB series or the Destiny Breast series. This is Destiny Breast 11, which talks about the use of new adjuvant trastuzumab deruxtecan. We are aware of this new kid on the block, which is either alone or followed by paclitaxel and trastuzumab along with pertuzumab versus the usual dose-dense AC and the use of taxane along with pertuzumab and trastuzumab for high-risk HER2-positive early breast cancer. Thank you very much, Astra, to provide me the educational material here. And has been, of course, presented at the ESMO Congress, which was held in Berlin last month. This is the study schema. If you look at the patient population, they were used previously untreated HER2-positive early breast cancers. The good thing is that they have taken both hormone positive as well as hormone negative. We know that hormone positive is a subset which is along with HER2 becomes a little difficult in terms of achieving an adequate PCR is concerned. HER2 negative with HER2 positive, I mean, hormone negative with HER2 positive definitely historically has shown a good PCR rate of about 50% or so. They have defined high risk as usual wherever we decide to use pertuzumab. So historically, pertuzumab has been used in NACT in early breast cancers in patients who have more than T2, that is T3 and above, or node positive. They have also taken inflammatory breast cancers here, and the stratification used here is based on the hormone status and the HER2 status. So fairly straightforward patient population, the need of the hour, and they have randomized into three arms. The first arm, of course, being the experimental arm of using TDXT upfront, followed by 4 cycles of TDXT, followed by 4 cycles of THP, that is taxane, along with the dual anti-HER2. The second arm here, of course, is the conventionally used. Nowadays, of course, people do have graduated to the use of TCHP, but they have used the comparative arm of dose dense AC, followed by THP, again 4 plus 4 format. And the third arm was quite adventurous with the use of just TDXD for 8 cycles. This, of course, we'll discuss further, and followed by surgery and post neoadjuvant protocol. Here again, if the standard guidelines suggest if the patient has achieved PCR, then the patient straight away goes for the concomitant adjuvant trastuzumab and pertuzumab to complete 1 year, and or hormone therapy depending on the hormone status. So the primary endpoint here in this study was the PCR rates, and the secondary endpoints was the EFS and the safety profile, overall survival, etc. Additionally, they did have another cancer outcome, which was residual cancer burden. So these were the results. If you look at the primary endpoint of PCR, very, very impressive PCR rates of 67.3% versus the dose dense AC arm having a 56%. So the delta of 11.2 is definitely very encouraging in this subset of patients. Do I mean, to just to remind everybody, they have used both hormone receptor positive and negative patients. So in the intention to treat population, having a PCR rate of 11.2% difference definitely is encouraging. So if you look at the hormone receptor status positive patients, the graphs which are in the middle, the delta is about 9.1%. So as expected, I think we will have a better response in patients who are hormone receptor negative. And here, if you look at the PCR rates, are a humongous 83%. So this is a very, very encouraging result. So 83% of hormone negative, HER2 positive patients achieving PCR is really remarkable in this. So there is no doubt we can conclude that the neoadjuvant TDXD did demonstrate a statistically significant improvement in PCR versus the dose dense AC and THP arm. And the improvement was seen in both the arms. So this was the EFS curves. If you look at them, they had a very nice separation round about, say, about 1.5 years to 2 years. And thereafter, there's a little bit of crossover. So these data, of course, is quite immature to comment, but there is definitely a significant trend towards the improvement in EFS. There is the confidence intervals which are crossing one. So that is a bit of concern. But then this data is, of course, very immature. So we can't really conclude anything out of it. Another encouraging point in the DB0 in this DB11 trial was the fact that there were fewer side effects. If you look at the grade 3 adverse events in the experimental arm, they were in fact less than what we usually see in the dose-dense arm. So that is one concern with the use of anthracyclines, especially in the dose-dense did lead to, say, the more than three grade 3 adverse events. If you look at it, we had a significant amount of patients. There were 60% almost patients of the dosed in AC arm having grade 3 adverse events. So that was not there in the experimental arm. So in either patient. So overall, the treatment related adverse events were definitely much lesser in the experimental TDXD and THP arm compared to the other ones. So that is definitely a encouraging sign. So to conclude, DB11 is a very encouraging trial. Is it a practice changing trial? I would suggest the word of practice shaping rather than practice changing as of now, because the data is immature as far as the EFS and OS is concerned. There are concern, if you ask me, the key takeaway of this trial would be the fact that they have included both the high risk hormone positive and hormone negative patients of HER2 positive subset. So that is something which is encouraging. An 83% PCR rates is really remarkable. And there's no doubt here that a delta of 11.2 in the intention to treat population is definitely very encouraging. But if you cap up with, but there are issues, of course, when you compare apples to apples. If you look at the comparative arm of having dose dense AC, I'm sure many of the crowd, it'd be interesting to know from others in this discussion as to how many actually use dose dense AC and THP in the new adjuvant protocols. I for one can say definitely that we have moved on to TCHP for most of the patients where we decide to use the dual anti-HER2. So that is something which is of a concern because the comparative arm is really not the one that we standard of care. And the third part, of course, would be the dilemma that suppose these patients do not achieve PCR, what then? Do we go ahead with TDM1 or continue with TDXD? Because both of them are ADCs to remember. So these are some questions that need to be answered before it actually becomes practice changing. So it is practice shaping as of now, but definitely encouraging results as far as the PCRs are concerned. So that's one thing. Safety profile is another good takeaway from this trial. Very favorable safety profile with the use of TDXT upfront. So and that's all. I think that's the takeaway point. I thank everyone for the patient listening and moving on. I'm done. Yeah.
Yes,
Thank you.
so
Thank you so much, sir, for your such an informative and insightful presentation. And moving ahead with our agenda, I would like to invite Dr. Rajiv Bhattacharya ji, sir. He is a consultant in the Department of Medical Oncology at Pearls Hospital, Kolkata, for Destiny Breast 05. Over to you, sir.
Yeah, I will request you to share my slide from your screen.
Yes,
First
sir.
of all, at the outset, I would like to thank Mahapatra sir, who has been nothing less than a guiding light in my career. So today, I also have thanked AstraZeneca for inviting me. This is a DB05, the Destiny Breast 05, which is a trial on replacing trastuzumab emtansine with TDXD in high-risk HER2-positive breast cancer patients who do not achieve a pathological complete response after the neoadjuvant therapy. So this is an interim analysis of much full text has not been published yet. Let's move on. Next slide, please. So TDXD versus trastuzumab emtansine. This is the interim analysis of Destiny Breast 05. Next slide. So this is the current treatment landscape as per the Catherine trial. What we use is after receiving neoadjuvant chemotherapy, we do the surgery, and if we see that there is residual disease present, in that case we do not continue trastuzumab. We give TBM1 as an adjuvant therapy. We think that the clone that has developed resistance to uh, trastuzumab anti-HER2 therapy, so you need something newer to treat those resistant clones. And although the patients who are present with advanced locoregional disease or positive nodal status, after neoadjuvant therapy, they have a 3-year IDFS rates of 76 and 83%. And the 7-year IDFS rates are 66.7 and 71.6%, respectively. And unfortunately, adjuvant TDM1 did not reduce CNS vector sensitivity to trastuzumab, and hence it's indeed a high unmet medical need for these high-risk patients. So this was uh, uh, the basic background about the DB05. Next slide, please. So this is the basic study design. So the eligibility criteria would include the residual disease after neoadjuvant therapy, and high risk was defined as presentation prior to neoadjuvant therapy as an inoperable early breast cancer, let's say clinically T4, N0 to N3, or clinically T1 to T3 or N to N3 patients, or operable early breast cancer like T1 to T3, N0 to N1 with axillary node positive disease after neoadjuvant therapy. Right? So mostly locally advanced or early breast cancer, operable early breast cancer who still present with residual nodal disease. So, and the HER2 was centrally confirmed. So they were randomized into 1:1 ratio, nice 800 division. TDXD has a rate of 5.4 milligram per kg and TDM1 has a dose of 3.6 milligram per kg. This is the usual dose in breast cancer. And the concomitant adjuvant hormone therapy was allowed for local practices. And if administered, radiotherapy could be initiated concurrent with study therapy or completed prior to initiation of study therapy. And also, most importantly, the interstitial lung disease monitoring program was there who received treatment with radiotherapy. So all patients had baseline non-contrast low-dose chest CT during screening, and then they would have low-dose chest CT screening 6 weeks after start of study therapy, and then every 12 weeks while on therapy, and a 40-day follow-up. Sequential RT patients had additional low-dose chest CT after completion of RT prior to the start of study therapy. Next slide. So this was the primary endpoint of invasive disease-free survival, and we can see that um, the 3-year IDFS was 92.4% with TDXD compared to 83.7% with TDM1. There was a delta of 8.7%. It was highly statistically significant. The hazard ratio being 0.47. It's a really impressive hazard ratio. Excellent. So the key secondary endpoint was disease-free survival, and you can see the 3-year DFS was 92.3% in the TDXD arm compared to 83.5% the TDM1, the almost 9% delta at 3 year DFS. Next slide. The distant relapse-free interval, the brain mets free interval, and overall survival. So, in the distant recurrence-free interval, at the 3 year, DFSFI was 93.9%, that's 86.1%. Between TDX and TDM1, hazard ratio was 0.41, highly significant. For BMFI, you had 97.6% with TDXT compared to 95.8%. This was not statistically significant. The overall survival, again, is 97.4 versus 95.7 percentage at 3 years. This was also not statistically significant. Next slide. So these are the treatment-related adverse events. So the most common adverse events with the TDXT was, of course, nausea. But apart from that, neutropenia, low WBC count, fatigue, anemia, and thrombocytopenia, these were also associated, mostly grade 3, associated with TBXT. And TBM1 was a special grade 3 toxicity was thrombocytopenia. That's what produced the maximum number of scare and a little bit of grade 3 elevations in liver enzymes as well. So apart from that, there were no new safety signals in the patients with the experimental arm of disease. Next slide. I think we all are very much concerned about the interstitial lung disease or pneumonitis in TDXT patients, and as you can see, only 0.9% of the patients. The total, there was nearly 10% of patients who had pneumonitis with TDXT, whereas less than 2% had pneumonitis with TDM1. But you can see that in TDM1 there were no serious pneumonitis, but in TDXT there were about 1% of the patients who had suffered an interstitial lung disease, and most important thing is that there was no grade 4. So there were just 7 patients developed grade 3 ILD and 2 of them died. So that's why we do not wait. We do not wait for grade 3 ILD to happen in our patients with TDXT. We stop it as soon as the grade 2 is reached. We delay and we allow the drug to be stopped until the pneumonitis goes down to grade 0. So left ventricular dysfunction, there were no, just a few grade 3 LV dysfunction seen with either of the arms, just 0.2 and 0.4%. Nothing there. Next slide. So to conclude, Destiny Breast 5 demonstrated a statistically significant and clinically meaningful improvement in invasive disease survival and DFS with PTSD. SSTDM1 is diagnosed patients with positive early breast cancer and with residual invasive disease after neoadjuvant therapy. IDFS benefit was consistent across all pre-specified subgroups. Benefit in DRFI with TDXT was also observed. CNS metastasis and deaths were numerically fewer with TDXT versus TDM1, although we have to understand that it was not statistically significant. Overall safety profile of TDXT was manageable with no new signals. More than 72% of patients completed treatment and was comparable in both arms. An adjudicated drug-related ILD was reported in 9.6% of patients receiving TDXT, with the majority being grade 1 or 2 and reversible. So that suggests that the risk is manageable with appropriate monitoring and timely intervention. Adjuvant TDXT demonstrated superior efficacy with manageable safety in patients with high risk positive early breast cancer and flexible disease. After neoadjuvant therapy, representing potential standard of care in this post-neoadjuvant setting. Is it again? Is it practice changing? I don't know. The overall survival was not different, and we do not know whether giving TDM1 now uh, and holding on to the more toxic TDXT for later line produce any benefit or not. I think time will only say the jury is still out on that. With that, I would like to end my talk and pass the baton back to Mr. Dog.
Thank you so much, sir, for a very informative talk. And now our next speaker is Dr. Debapriya Mondal, sir. He is a consultant in the Department of Medical Oncology at Apollo Hospital, Kolkata, and he is going to speak on Destiny Breast 09. Over to you, sir. Hello.
Hello, good evening.
Yes, sir.
I hope my screen is visible.
If you can just put it full screen, sir. Yes, please.
Okay. So I'm going to discuss about a recently presented research at the last ESMO in Berlin. Trastuzumab deruxtecan plus pertuzumab versus taxane plus trastuzumab plus pertuzumab for patients with HER2-positive advanced or metastatic breast cancer. This is additional analysis of the Destiny Breast 09 in key subgroups of interest. This was originally presented by Dr. Sibyl Lovell. And so let's look at the schema of this trial. Destiny Breast 09, the trial design was that of a randomized multi-center open label phase 3 study. The patient population were first line HER2 positive advanced or metastatic breast cancer. They had to have a disease-free interval of more than 6 months from their last neoadjuvant or adjuvant therapy. One prior line of endocrine therapy for patients who were hormone receptor positive were permitted. Asymptomatic brain metastasis were allowed. Now, the stratification factors were uh, de novo versus recurrent metastatic breast cancer, hormone receptor positivity or lack thereof, and they also stratified by the PIK3CA mutation status. Now, the three arms where the patients were randomly allotted in 1:1:1 manner, where CDHC plus placebo, and this arm was blinded until final PFS analysis. The other arm was CDHC plus pertuzumab. This was a chemotherapy-free arm, and the control arm was trastuzumab plus pertuzumab plus taxane. That is basically based on the prior standard of care, that is the K-Paxos arm. The endpoints were primary endpoint progression-free survival as assessed by a blinded independent committee, and key secondary endpoints were objective survival, progression-free survival in certain subgroups, objective response rate, duration of response, PFS, safety and tolerability. If TBC was discontinued owing to adverse events, patients could switch to trastuzumab. This was with the exception of ILD. Concurrent use of endocrine therapy was allowed for those with hormone receptor disease after 6 cycles of TDHC or discontinuation of taxane to make it more harmonized and balanced because in one arm at least there are 6 cycles of chemotherapy. Now, TDHC plus pertuzumab demonstrated a significant and clinically meaningful benefit in progression-free survival, which was consistent across all subgroups. The hazard ratio was of 0.56 versus PHP, which was highly significant. This meant a 44% reduction in the risk of disease progression or death in favor of TDHC plus pertuzumab versus PHP. The median PFS was 40.7 months versus 26.9 months. That is around 14 months of absolute difference. Median duration of response was more than 3 years with TDHC plus pertuzumab. The median was not reached with maintained complete response in 15.1% versus 8.5% with PHP. The OS data is yet to be disclosed and it is, of course, immature, but it suggests a positive trend favoring TDHC plus pertuzumab with a hazard ratio of 0.60 for second PFS PFS 2. And TDHC plus pertuzumab, the safety data was consistent with known profile of individual drug options, and there was no new concern with its safety. Now, if you look at the Kaplan-Meier curves, you can see the TDHC plus pertuzumab combination demonstrated a clinically meaningful progression-free survival benefit versus PHP, regardless of whether at presentation, it was a de novo metastatic or advanced disease, or it was a recurrent metastatic or advanced disease. The median PFS for de novo metastatic or advanced disease was not reached versus it was 31.2 months in the THP arm with a hazard ratio of 0.49. So almost more than 50% reduction in risk of death or progression. And for recurrent disease, the same median PFS was 38 versus 22.5 months with a hazard ratio of 0.63. So we can see that the PFS benefit was there irrespective of recurrent or de novo status of metastatic disease. Now, if you look at the hormone receptor status, then PFS in hormone receptor positive was 38 months versus 27.7 months with a hazard ratio of 0.61, and in hormone receptor negative it was 40.7 months versus 22.6 months with a hazard ratio of 0.52. So again, it is very clear that TDHC plus pertuzumab demonstrated a clear superiority in terms of PFS compared to THC regardless of the hormone receptor status. Now, what about the objective response rate and duration of response by hormone receptor status? The duration of response again was better in CDHC plus pertuzumab arm irrespective of hormone receptor status. It was 26.4 months in the THC, and compared that there was a for 39.2 months in the uh, TDHC plus pertuzumab arm. If you look at the response rate again, the objective response rate was 81.2 versus 77 in hormone receptor positive, and 89.8 versus 80.3 in hormone receptor negative. And as you can see, the uh, complete response rate was almost double. Now, PIK3CA mutation status, it is important, this is a poor prognostic factor, and in this PIK3CA mutated cohort, it was 36 months of median PFS with TDXT plus pertuzumab versus 18.1 months with THP. And in PIK3CA non-mutated, it was 40.7 with 32.7 months compared to 32.7 months. You can see that TDC plus pertuzumab combination again showed a clinically meaningful PFS benefit regardless of PIK3CA mutation status. But I think we can also look at this data like in a different manner that in PIK3CA mutated where PHP did not fare as well with 18.1 a month of median PFS, the TDP plus pertuzumab could still drive the benefit. So that's something to look out for, and this is again a very important finding in a poor prognostic subgroup. So objective response rate and duration of response by PIK3CA mutation status. The duration of response rate, of course, again was much better with TDXT plus pertuzumab, and the objective response rate was also favoring TDXT plus pertuzumab combination regardless of its utility. So safety, I'm just summarizing the safety findings. So any treatment emergent side effect that was, I mean, almost similar in both the arms, and any side effect, any adverse event that could possibly be related to treatment and more than grade 3 was seen in around 57% with TDXT plus pertuzumab, with chemo plus trastuzumab plus pertuzumab, it was 61%. And adverse events leading to discontinuation was actually higher in the trastuzumab pertuzumab plus chemo arm. It was lower in the trastuzumab pertuzumab plus trastuzumab deruxtecan arm, and adjudicated drug-related any grade pneumonitis was 14.5% and 9.4% in the so around 9 to 14% in the TDXT plus pertuzumab arm compared to only 1% in the trastuzumab pertuzumab chemo arm. So the risk of ILD is there, and it needs special caution, periodic reassessment, sometimes with periodic imaging, as we have seen with the use of NBCT in the presentation that Dr. Rajiv Bhattacharjee just described. So we have to be vigilant about this finding of pneumonitis. To conclude, in this subgroup analysis of Destiny Breast 09, first-line treatment with TDXT plus pertuzumab demonstrated a clinically meaningful PFS benefit versus PHP regardless of prior treatment, hormone receptor status, or PIK3CA mutation status, reflecting that its applicability in the broader overall population. The duration of response consistently favored PDXT plus pertuzumab with a median of more than 3 years, and the complete response rates were also much higher in favor of TDXD plus pertuzumab. No new safety signals were identified for TDXD plus pertuzumab, and safety outcomes of each arm were broadly similar with what has been reported in prior studies. The TDXD plus pertuzumab represents an effective first-line treatment for patients with HER2 positive advanced or metastatic breast cancer, regardless of prior treatment, hormone receptor, or PIK3CA mutation status. Thank you.
Thank you so much, sir, for that very comprehensive update. And now we will start our session two, that is HR positive and breast cancer. For that, I would like to invite our first speaker, Dr. Paulami Basu, ma'am. She is a consultant in the Department of Medical and Hemato-Oncology at Netaji Subhash Chandra Bose Cancer Hospital, Kolkata, and she will speak on Serena 6. Over to you, ma'am.
Kindly share the slide.
Yes, ma'am.
First of all, thank you for giving me this opportunity. Thank you, sir. So my talk is on regarding the role of camizestrant along with CDK4/6 inhibitors for hormone positive, HER2 negative metastatic breast cancer. It's a phase 3 double blind ctDNA guided Serena 6 trial. Next slide. So in this particular trial, they use this camizestrant drug along with the CDK4/6 inhibitor, either palbo or ribo or abemaciclib, for the treatment of hormone positive, HER2 negative advanced breast cancer before radiological disease progression. So it's a phase 3 double blind ctDNA guided Serena 6 trial. Next slide. So we all know that for hormone positive, HER2 negative advanced breast cancer, initially mostly we use CDK4/6 inhibitor along with aromatase inhibitor. So in this particular trial, they try to switch from AI to aromatase inhibitor to camizestrant along with the continuation with CDK4/6 inhibitor with the help of this ctDNA test by Garden 360. So it's a phase 3 study, and in this particular trial, they showed that there was some sort of PFS benefit. So for the finding from this Serena 6 have the potential to become a new treatment strategy in first line setting for hormone positive, HER2 negative advanced breast cancer. Next slide. So now coming to the epidemiology, the incidence rate of hormone positive HER2 negative breast cancer, approximately around 70% of breast cancer are hormone positive HER2 negative. And we all know that for hormone positive HER2 negative case, we have options of the CDK4/6 along with hormonal therapy. And now coming to ESR1 mutation rate, we know that the ESR1 mutations are rare, less than 5% at diagnosis of advanced breast cancer. But if we see the progression, but in emerge during the first line AI plus CDK4/6 inhibitor, the detection rate is high. It's around 40% of the patient have positive ESR1 mutation. So in this particular trial, they use this drug, camizestrant, the oral drug, along with the CDK4/6 inhibitor. Next slide. So we know that ESR1 mutation in this Serena 6 trial, this ESR1 mutation can be detected in ctDNA liquid biopsy prior to progression on AI plus CDK4/6 inhibitor. So before disease progression, they try to detect ESR1 mutation rate by ctDNA. And we know that according to the PADA trial design, in this PADA trial, they switch from AI to fulvestrant plus palbociclib, and there was a significantly improved PFS benefit. So in the Serena-2 trial, they used single-agent camizestrant, which showed a significantly improved PFS if they compare fulvestrant versus this camizestrant. So from this PADA-1 trial and Serena-2 study, now coming to Serena-6 trial, where they use this particular drug, camizestrant, along with a CDK4/6 inhibitor before disease progression. Next slide. So in this particular trial, around 3,325 patients were screened, and out of 3,000 patients, only 548 patients were detected ESR1 mutation positive. And there were some stratification factor, right? Next slide. Yes, so now coming to study design, it's a phase 3 randomized double-blind placebo-controlled study where they include all the hormone-positive, HER2 negative advanced breast cancer patients. All the patients have received AI plus CDK4/6 inhibitor, either palbo or ribo or abemaciclib. ESR1 mutation detected in the ctDNA based with no evidence of radiological disease progression. They were randomized into two arms, total 315 patients were there. One arm received this particular drug, camizestrant, dose is 75 mg once daily, along with the CDK4/6 inhibitor, and the second arm received AI plus CDK4/6 inhibitor. There are some stratification factors like whether there is visceral mets or non-visceral mets, whether the ESR, the detection rate, the time duration, the time from initiation of AI plus CDK4/6 inhibitor to randomization, whether it is less than 18 months or more than 18 months, the type of CDK4/6 inhibitor used like palbo versus ribociclib versus abemaciclib, and the ESR mutation detection at the first stage or the subsequent versus the subsequent stage. The primary endpoint was to see the PFS by investigator, and the secondary endpoints were to see the PFS2 rate, the overall survival rate, the safety profile. Next slide. Next slide. Now coming to result. Next slide. So these are the baseline characteristics. Mostly around 76% of the patient received palbociclib, around 15% of the patient received ribociclib, and 9% of patient received abemaciclib. And see the most common ESR1 mutation at base level, mostly D538G mutation is very high, around 45% of the patients had this particular type of mutation. Next slide. See the result. There was a clear-cut separation of these two Kaplan-Meier curves. The median period was 16 months in the camizestrant arm, whereas in the placebo group, it was 9.2 months. Next slide. So this is a forest plot which showed that irrespective of CDK4/6 inhibitor, the type of CDK4/6 inhibitor, irrespective of the mutation status, the type of ESR1 mutation, there was consistent benefit in this particular drug. Next slide. So now quality of life, which is very important, time to deterioration in health status. Again, there was much more benefit in this camizestrant group along with the CDK4/6 inhibitor, 23 months versus 6.4 months. Next slide. And the HR ratio was less than 0.53. PFS2, again, there was benefit and the hazard ratio was 0.52. Next slide. These are all about the efficacy, and we can say that there was more PFS benefit. Now coming to the safety profile. Next slide. Mostly there was a CDK4/6 inhibitor induced cytopenia like neutropenia, anemia, thrombocytopenia. The two type of side effects are in the camizestrant group like photopsia and the dry eyes, and some patient develop back pain and headache. Next slide. So now coming to conclusions, we can say that from Serena-6 trial design, we can say that switching AI to camizestrant along with the continuation of CDK4/6 inhibitor guided by the emergence of ESR1 mutation during first line of therapy ahead of disease progression, means which is very important. Without radiological progression, we can use this particular drug, and according to this trial, we can say it significantly improved PFS with hormone positive, HER2 negative advanced breast cancer patient. And again, there was a quality of life is much better in this camizestrant group. And this in particular, in this trial, we can say that the Serena-6 is the first global registrational phase 3 study, which demonstrate clinical utility of ctDNA monitoring to detect and treat the emerging resistance in breast cancer. So we can say that from the Serena-6 study, yes, though we don't have any waste benefit data, we have to wait. But from this Serena-6 study, we can say that yes, we can use this particular drug before disease progression. Next slide. So I think with this, I would conclude my talk. Thank you.
Thank you so much, ma'am, for sharing that important updates. And for our next presentation, I would like to invite Dr. Mukesh Patekar, sir. He is Associate Director in the Department of Medical Oncology at BLK Max Super Specialty Hospital, New Delhi, and he is going to speak on e-Vera trials. Over to you, sir.
Thank you. I hope my slides are visible.
Yes, sir.
I'm thankful to Dr. Mahapatra sir and Dr. Jaitu sir for having me here. So, so after excellent talk by Dr. Paulomi, which she has established and enlightened us on the role of addition of selective estrogen receptor antagonist, as camizestrant, when we get the ESR1 mutation. Now moving further, so e-Vera trial address this giredestrant, an oral selective estrogen receptor antagonist and degrader, along with the everolimus in a patient with estrogen positive, HER2 negative advanced breast cancer, previously treated with CDK4/6 inhibitors. That is the primary results of phase 3, this e-Vera study. So if you look at the key design, it was a global randomized open label phase 3 trial. Estrogen positive HER2 advanced breast cancer, less than equal to 2 prior lines of endocrine therapy, progressive disease or relapse during or post CDK4 inhibitors or along with endocrine therapy. There shouldn't be any chemotherapy and measurable disease by RECIST 1.1. And they also stratified based on the factors like whether they have received fulvestrant or not, estrogen receptor mutation present or not or indeterminate, site of the disease, and they were randomized into the two arms. One was the giredestrant. It is a selective estrogen degrader along with everolimus, and comparator arm was standard of care endocrine therapy. This could be the exemestane, fulvestrant, or tamoxifen along with the everolimus 10 mg. Usually we give dexamethasone mouthwash prophylaxis as it was standard by the Swiss trial protocol. The treatment was continued till progressive disease or unacceptable toxicity. And these were the primary endpoints. Investigator assessed PFS in whose tumor had a ESR mutation, PFS in ITT population, and the key secondary endpoints were OS and investigator assessed overall response rate and duration of the response. So if you look at the ESR1 mutation population, we know that ESR1 is the most common mutation, almost 40% on CDK4 we get this kind of mutation. Here also, there were 102 patients, they had a ESR1 mutation and 105 in standard of care arm. So the median PFS was 9.99 months versus 5.45 with hazard ratio of 0.38. So we can see that at 6 months, this PFS rate was 66 versus 38%. At 12 months, it is 40 versus 15%. And over the period of time, these curves are kept separating apart. So the combination therapy with Gerardestant plus everolimus led to the clinically significant, meaningful for 62% reduction in the risk of progression or death with ESR1 mutation population. So if you look at this part of the graph where exploratory analysis was done, when you compare this Gerardestan and everolimus with exemestane fulvestrant, because generally exemestane used along with the everolimus in Bolero trial, and fulvestrant is second line common used drug. In both comparison, the hazard ratio was and it was favoring Gerardestan everolimus as compared to standard of care. So if you look at the intensive treated population, again, so there were around 183 patients and 190 in each arm. Median ITT PFS was 8.77 months and in standard of care of 5.49. Here also there was almost 3.2 months benefit with hazard ratio of 0.56. At 6 months, the PFS rate was 57 versus 39, and at 12 months, it was 34% versus 18%. So interim OS in the estrogen receptor mutation ITT population. So ESR1 mutation population, after a brief period of overlap at 12 months, the curve starts separating. At the median, your time of evaluation, the median OS was not reached in Gerardestan arm versus 21 month in ITT standard care arm, and in ITT population it was not reached in Gerardestan arm versus 26.87. So those who don't have ESR1 mutation, so again this is exploratory analysis, was not enoughly powered to address this question, but however the median PFA was here also 5.72 versus 5.52 with hazard ratio favoring the Gerardestan everolimus arm. An interim OS was not available in both arm at the time of analysis. Coming to the adverse view, generally stomatitis, diarrhea, these are everolimus related toxicity, fatigue, nausea, pneumonitis. So they are also commonly seen with the everolimus rather than the other thing. And other side effects like hepatotoxicity and electrolytes, they were comparable in both arms. So if you look at the selected adverse events, so bradycardia, like and photopsia, like in also chemistry, the serenatics also, they were also had photopsia, but here we didn't get anything. And bradycardia, it was like grade 1 and 2, it was 7 patients and 1 is under of care. To come to the conclusion, the next generation oral selective estrogen receptor degrader, that is Gerardestan, in combination with everolimus, showed a statistically significant and clinically meaningful improvement in investigator assessed PFS. ESR mutation population, 62% reduction in the risk of progression or death. In ITT population, 44% reduction in the risk of progression or death. There was a consistent benefit with Gerardestan and everolimus across the key subgroup like overall response rate and duration of response benefit was also observed. The safety profile was manageable and consistent with the known safety profiles of the individual drugs, and there were no unexpected safety findings. The Gerardestan everolimus may represent a new effective all oral treatment options in post CDK4/6 setting for patients with estrogen receptor mutation, estrogen receptor positive and HER2 negative advanced breast cancer subset. With this, I like to conclude. Thanks for opportunity.
Thank you so much, sir, for very wonderful performance, for wonderful presentation. And next, we will start with our third session, that is triple negative breast cancer. And for that, I would like to invite our first speaker, Dr. Tanmay Mondal, sir. He is a consultant in the Department of Medical and Hemato-Oncology at Manipal Hospitals, Kolkata, and he's going to speak on Trophion Breast 02. Over to you,
Okay.
sir.
Okay. Can you share the slides?
Yes, sir, I'm sharing the slides.
Okay, so we'll be discussing today the tropion study. It is the use of first-line datopotamab deruxtecan versus chemotherapy in patients with locally recurrent inoperable or metastatic TNBC for whom immunotherapy was not an option earlier. And this is the primary results from this tropion breast 02 study. It's a phase 3 study. Next slide. So this was presented in this year's ESMO 2025 in the ESMO Congress. Next slide. So this is the study design with dato-DXT 6 mg per kg every 3 weekly in one arm with investigator choice of chemotherapy in the other arm. The primary endpoint, dual primary endpoint being overall survival and PFS by independent investigator independent review. And the secondary endpoints was PFS by investigator assessed and overall response rate and the safety profile. Randomization was stratified based on the geographical status and the PDL1 status also. Next slide. So this is the PFS by the blinded review that was at the end of 12 months. It was 45% in the experimental arm compared to 25% in the comparator arm, and also it demonstrated a statistical significant and meaningful clinical improvement in the PFS with a statistical significant value with an hazard ratio of 0.57. That means there was reduction in the risk of progression or death by 43%. Next slide. Progression free by investigator assessment PFS was there was a investigator assessment was consistent with the PFS by the BICR with a median PFS of say 9.6 months compared to 5.2 months, absolute benefit of 4.4 months. Next slide. This is the overall survival. Median OS was 23.7 months compared to 18.7 months in the comparator arm with a hazard ratio of 0.79. It demonstrated a statistically significant and clinically meaningful importance in the overall survival compared to investigator choice chemotherapy. Next slide. This is the safety profile. Median total duration of treatment in the dato-DXT arm was 8.4 months compared to 4.1 months in the investigator choice. And the total exposure of more than 12 months was seen in 35% of the patient compared to 9.4% in the opposite arm. So despite more than double the median duration of treatment at DXT, the rates of serious adverse events were similar and discontinuation rates were lower with the dato arm. Next slide. The common treatment related adverse events mostly dry eye, stomatitis, nausea, and also some patients had neutropenia, anemia, and leukopenia as the side effects. Next slide. So this is the treatment related adverse events for dato-DXT. In the dato-DXT arm, events led to dose interruptions, reductions, and discontinuation in 3%, 11%, and nil patients respectively. More than grade 2 events resolved to grade 1 in 90% of the patients at the data cutoff. Next slide. So the conclusions of the Tropion Breast 02 met both the dual primary endpoints. First line dato-DXT demonstrated statistical significant and clinically meaningful improvement in the overall survival and PFS over investigators' choice chemotherapy. OS, there was a reduction in the risk. Hazard ratio was 0.79 with PFS in blinded review was around 0.57. More than 5 month improvement in both the median OS and the PFS. The dato-DXT safety profile was manageable and generally consistent with the known profile. Despite more than double the median duration of treatment, rates of grade 3 and serious adverse events were similar and discontinuations were lower with the dato-DXT arm. The Tropion Breast 2 enrolled patients who were representative of the real-world TNBC population, including those often excluded from the clinical trials. So these results supports the use of dato-DXT as the new first-line standard of care for patients who are locally recurrent, inoperable, or metastatic TNBC in whom immunotherapy is not feasible. Next slide. Yes, so with this, I end my talk and over to the sponsors.
Thank you so much, sir, for sharing this uh, key insights. And now I would like to invite our next speaker, Dr. Satya Sarangi, sir. He is a senior consultant in the Department of Medical Oncology at Medanta, Noida, in New Delhi, and he is going to speak on Asian 3003. Over to you, sir.
So, good evening, and thanks to the organizers for giving this opportunity. I'll be talking on SN03. I would request the organizers to kindly project my slides.
1 minute, sir. Okay.
Okay. Uh, so, this is regarding the primary results from SN03. It's a randomized phase 3 study of sacituzumab govitecan versus the chemotherapy in patients with previously untreated metastatic TNBC who are unable to receive PD-L1 inhibitors, PD-1 or PD-L1 inhibitors. Next slide. So if you look at the study design, the eligible candidates were like PDL1 negative tumors, that is defined as CPS less than 10, PDL1 positive tumors, but have been previously treated with a PD1 or PDL1 inhibitor in curative setting, or ineligible due to a comorbidity. It should have been a more than 6 months gap since the treatment in curative setting, and previously treated and stable CNS metastases were allowed. And they were randomized as 1:1. It was a sample size of 558 patients. They were randomized to either sacituzumab govitecan at 10 mg per kg, day 1 and day 8 of 28-day cycle, versus the physician choice of chemotherapy in the form of paclitaxel, gemcitabine, carboplatin. The endpoints are the PFS by blinded independent central review. Secondary endpoints included OS, overall response rates, safety, and quality of life data. Here, important thing to remember is the eligible patients were offered crossover to second line sacituzumab through the study following the BICR verified disease progression. There were stratification factors based upon the geographical regions and is whether it is a de novo versus recurrent within 6 to 12 or after more than 12 months. Next slide. So if you look at the Kaplan-Meier curve for the progression-free survival, here there is a difference between the two curves, and it not only showed a statistically significant but a clinically meaningful improvement also in PFS, with a 38% reduction in the risk of disease progression or death. Next slide. So even as per the investigator assessment also, it improved the PFS as compared to the chemotherapy for those subset of patients who are not eligible for PDL1 inhibitors. Next slide. Coming to the duration of response and the objective response rates, here is an important fact to notice that although the objective response rate between the sacituzumab govitecan and chemo is almost neck to neck, but there is a remarkable difference in the duration of response. So this tells us that it may be the response rates are not high with this drug, but those patients who are responding, they are going to do well for a prolonged period of time, which is very important in these subset of patients in which we do not have an option of immunotherapy. Next slide. Coming to the overall survival, the study is not yet matured, but we can just look at the initial trends. And if you see the number of events and the median OS, it was 21.5 versus 20 months with a hazard ratio of 0.98. And at 12 months and 24 months at both endpoints, numerically a bit higher on the favoring the sacituzumab arm. And if you look at the PFS2, here also the median PFS2 is 18.2 versus 14 months. So it was 4 months longer with sacituzumab. Next slide. Coming to the safety profile, the most common being the neutropenia, nausea, diarrhea, the fatigue, and the GI side effects, which if you see as compared to the chemotherapy, it is almost similar. There is no any alarming new adverse event that have been seen with this new drug. Next slide. So to conclude, sacituzumab govitecan has led to a statistically significant and a clinically meaningful improvement in PFS with, as compared to chemotherapy. The PFS benefit was observed across all the key specified subgroups. Overall response rate, despite being similar, but is resulting into a longer duration of response with this sacituzumab ADCs. OS, yes, it is yet to mature. But regarding the safety, it has been consistent with its known profile. With the use of important point is like use of prophylactic GCSF is advised, and the rate of treatment discontinuation rates are also low with sacituzumab. So this SN03 data supports the role of sacituzumab as a potentially new standard of care for patients with previously untreated metastatic TNBCs who are not a candidate for PDL1 or PD1 inhibitors. Next slide. So thank you.
Thank you so much, sir, for sharing this valuable updates. And now we have our panel discussion. For that, I would like to invite our moderator, Dr. Joydeep Ghosh, sir. He is a senior consultant in the Department of Medical Oncology at Apollo Cancer Center, Kolkata. And our panelist, Dr. Indranil Ghosh, sir. He is a consultant in the Department of Medical Oncology at Apollo Cancer Center, Kolkata. Dr. Deepak Dapkara, sir. He is a senior consultant in the Department of Medical Oncology at Tata Medical Center, Kolkata, and Dr. M.V. Chandrakant, sir. He is a senior consultant and academic head in the Department of Medical Oncology at Narayana Health, Kolkata, and Dr. Isha Jaffa, ma'am. She is a associate professor in the Department of Medical Oncology at King George's Medical University, Lucknow. Dr. Mridul Malhotra, sir, he is a senior consultant in the Department of Medical Oncology at Manipal Hospitals, Delhi. And also, I would like to request our speakers to stay for the panel discussion as our speakers can also join the panel. Over to you, sir.
Yeah,
Uh,
thanks.
sir, should I share your slides?
Yes, you can.
Yes, I am sharing.
I think two of the panelists are not there, Dr. Isha and Dr. Bridul. So I'd like to request the speakers who presented the cases and the publications can join us. Dr. Tanmoy, Dr. Satya Sarangi, Dr.
Dr. Deva
Rajiv,
Priya and Dr. Deepak, Dr.
yeah, Dr.
Mukesh,
Devapriya,
everyone is
yeah,
here.
yeah. So okay, so next slide. Next slide. Next. Next slide. Yeah. So let us first discuss the Destiny Breast 11 study. So as discussed already, so it's a new adjuvant trial where the standard of care DDAC followed by THP was compared with TDXT single arm. We are not interested in that because that got closed. So let us compare the TDXT followed by THP versus DDAC followed by THP. Next slide. So here you can see, just for revision purpose, for the intention to treat population, there was 11% improvement in the PATCR rates. The PATCR rates was also different between the HR positive and HR negative groups. Obviously, the HR negative ones achieved a much higher delta of PATCR. The PATCR rates went up to almost as high as 83%. Next slide. And the forest plot also shows more or less majority of the subsets benefited from this combination of TDXT followed by THP. Next slide. So the conclusion was that TDXT THP showed the highest PATCR rates, and it also was statistically significant. There was an early positive trend towards CFS, and the safety profile was manageable. Next slide. So my question to first Dr. Deepak Dapkara. How many patients of early breast cancer you are currently managing, and how are user outcome? And also you can answer what is your standard of care neoadjuvant regimen?
Hello.
Yeah, you're audible. You're audible.
Hello,
Yes, you're audible.
can you hear?
Yes.
So presently we are managing HER2 breast cancer with neoadjuvant chemotherapy with targeted therapy. Now use of pertuzumab has increased. Nearly 50% patients are getting pertuzumab-based chemotherapy and targeted therapy.
Okay.
And what is
So
the
in
current standard of care in neoadjuvant setting? It is TCHP or EC followed by THP.
okay. So Indranila, once this paper comes out as
Current PET-CR with
publication.
current PET-CR is about 40 to 50%.
Okay. Okay. So, Indranila, in your practice, do you think this can be practice changing as far as your patients are concerned, keeping aside finances?
Yeah, we need to look at the final EFS,
Right.
and at present trend is there. Another thing is that they non-PAT CR they got TDM1. What is
Right.
the rationale of giving TDM1 after TDX?
Yes. Yes.
If,
Yes.
even if the patient is not having PAT CR but responded to TDXD, I think TDXD should have been continued.
Yes. Yes.
Yeah.
I think it was not done because there is no trial
Uh,
which is looked at
no, but
TDXT.
finally we need to decide because uh,
Yes,
uh, it is not that if TDXD is not working, then TDM1 will work.
of
Uh,
course.
yeah. So
So
that,
in
that
your
that
practice,
impacts
if
the
you have,
EFS.
right. So if you have a patient tomorrow who is willing for this regimen and does not achieve a PAT CR, you would like to continue the TDXT itself.
Yeah, because the another trial has shown that TDXD for non-PAT CR is better than TDM1.
Right. Absolutely. So you can combine these two studies and take a rational approach. Perfect. So Rajiv, what is your overall impression of this study? Do you think the uh, PATCR as a primary endpoint was good enough, or long-term EFS would have been a better endpoint? Rajiv Ashish. Okay. Devapriyo?
Jadida,
Ha,
uh,
Rajiv. Bol.
actually, the thing is that আমি জানি না যে we sorry we don't know whether this will lead to an overall survival benefit or not. That is always a question of sequencing that comes across. So if we utilize TDXD upfront, we do not know whether we probably can't use, probably TDM will not be that effective in the later lines, while TDXD can be very, very effective in later lines. So there could be a similarity of overall survival. So I think an OS benefit is the I think the way to go before we start practicing that.
OS or a EFS, because these are curative patients, so OS can be due to many other things.
Yes,
Malaria,
yes,
road traffic accident will also be into the OS. So,
yes, yes, yes.
right. So, next slide. Now coming to the DV05,
So,
which has
Rohita, so I'm Chandrakant here.
Chandrakant, bolo bolo.
I just wanted to make a comment. I think the control arm didn't have TCHP. We are no longer using
THP,
anthracycline.
yes, yes,
So
yes,
I think the carboplatin wasn't there, and they've used
right.
anthracycline regimen. If you want the best PAT-CR,
Yeah,
I think the comparator should be TCHP. So the comparator was not adequate. So PAT-CR 60% with TCHP. I think that's the.
yeah,
So this is
yeah.
not practice changing. I won't use TDXT in NACT as of now.
Okay. So coming to the DB05, so this is, I think, a very important study, more than the previous one. So PATCR not achieved, randomized into TDM1 versus TDXT, IDFS primary endpoint. So coming to Chandrakant, so will this be practice changing for you?
This is practice changing. Yes.
It is practice changing. Next slide. So, as mentioned previously, it's a statistically significant improvement in the IDFS with a hazard ratio of 4.47. Next slide. So these were the categories of the IDFS events, and majority were distal recurrences, which is very obvious. Next slide. So, Devopriyo, uh, so which are the patients? Are you there?
Yes, yes,
Okay.
I'm here.
Yeah, yeah. So in your clinic, if you have the access to both DB11 and DB5 type of patients, how would you sequence it if you had to use these two trials to change your practice?
I would still be using TCHP as my preferred neoadjuvant, and whoever is
Okay.
non-PCR with TCHP, I'll use
Okay.
TDHP for them. That would be my preference.
Okay.
Unless
Okay.
we have the long-term data of TCHP like we discussed, like you said,
Okay.
EFS at least. But then again, I'll in this particular situation, I'll perhaps also keep an eye on the weight because
Okay.
we are looking at around 10% ILD, and these patients are not uh, getting a fatal adverse events right away. But
Right.
ILD in long term can be life limiting for this very curable population. So
Mm-hmm.
perhaps a long term update where there is a, I mean, I'm not sure if they're looking into it. ILD
Mm-hmm.
leading to some sort of mortality in a long term patient. I
No,
mean,
only thing is that the ILD, if they develop, they will develop in the initial part only. It's not like they would develop after the
no,
treatment is completed.
but it doesn't go away completely
Yeah,
with
yeah. I mean, you mean the long-term
yes, 5 years
survivorship
down
issues?
the line.
Okay, okay, okay. So they can, they that might hamper a marathon running at a later time point, somewhere or the other.
Or
Okay,
likely
so
diabetes patients and a lot of
r-
later issues, pulmonary infections. And
right, right. So, Chandrakant, do you agree with the need for de-escalation of adjuvant chemotherapy, which can reduce toxicity?
De-escalation.
I think this question is not that much scientific, I would say, considering this issue. So, next question is, how would you see? Yeah.
Hmm.
So, in your
Yeah,
practice, you mean that you would we would go with the TCHP
right.
based, and then based on PATSIA, no PATSIA, you go to TDXT.
Correct. That's the practice.
Okay. Uh, Indrelda, would you follow the same pathway
Yeah, I will
or
follow the same pathway to rationalize the resources because
okay,
those who are having PATCR with TCHP, they will have good prognosis. So the poor
right?
prognostic ones, then I will use the best drug available, TDXT.
Okay, okay. Next slide. So this is DB09. I think this is another practice changing trial. This is going to be the most practice changing amongst the three. Which so we all know that Cleopatra regimen was the standard of care. I think for the last how much 10 years, maybe 7 to 8 years, and there was no trial which was looking into this space but had an impact. The Marian study was a failed study which tried to look at TDM1. But TDXD pertuzumab combination. Next slide. Just go to the next slide. Yeah, so the TDXD pertuzumab combination had definitely led to a significant improvement in the PFS, and you can see that the PFS is to the tune of almost 40 months. So coming to Tormoy. So next patient tomorrow, businessman. Will you use TDXD plus pertuzumab?
See, businessman, yes, of course, it's no, you can't say it's no, but of course, before
What
that,
is the
till
what
we
is
are.
the reason? What is the reason you're having a hiccup about the usage? I said finance is not a concern.
So, no, see, no hiccup because the with the usage, so much usage of trastuzumab plus pertuzumab, using TDXT in the first line makes that. I mean, how can we demean trastuzumab to such an extent? So that's the
Yeah,
only
but
hiccup.
Yeah. So, Indranila, what is your opinion?
So two things. One is when we give the maintenance pertuzumab and trastuzumab, patients are very happy. They are not
Yes.
having any symptoms whatsoever.
Yes.
And the subcut formulation is also available if somebody wants. So
Yes.
now this one, patients are bound to get toxicity.
Yes.
So whatever you do, so and they going for years, bit difficult.
Hmm.
And second thing is that after this what?
Yes.
Data
That's the
is
big question.
really limited. Now, of course, people will say if you get the best survival, giving the best drug upfront, then why
Hmm.
not? But
Right.
patients want that when disease progresses, you have something in hand, you change, then again disease response. So they have some kind of safety net that after this something is there. So
Right.
that is a bit difficult here.
So an ideal study would have been, I think that will not come from the sponsors, but uh, a type of a Sonia trial where TDXD in first line versus TDXD in second line, looking at the overall survival. That will answer a lot of questions. Chandrakant, you want to say something on this?
Yeah. So we have to classify HER2 positive into triple positive or only HER2 positive. If it is triple positive, after completing the docetaxel, you can add palbociclib
Yeah,
to the hormone.
platinum. Yeah,
If you add that,
yeah,
then the overall survival or the PFS is equal to the Destiny trial. So the Destiny trial in the comparator did not add palbociclib. So at least in the subset where it is triple positive, I would stick to Cleopatra and I will add hormone with palbociclib, and that is equal to the TDXT. Okay, I want to avoid TDXT. That is the funda because the quality of life is not great. And number two, in those patients who do not have brain metastasis in the baseline, I would use Cleopatra, even if it is only HER2 positive. And I would be little cautious on doing some CNS imaging because I don't want to miss a CNS metastasis because Cleopatra, especially the Pertutras2, may have CNS only as a mets. I would reserve TDXT plus pertuzumab for only that subset where the trastuzumab free interval is less than 1 year or who have upfront brain metastasis.
yeah. Okay. Uh, okay. So next slide. Dr. Mukesh, what is your take on this? Okay. So I think we have discussed the first three or four questions as shown here. And so Chandrakant, any change for the PIK3CA mutated patients?
Yes, so PIK3CA mutated, we only had alpelisib as a drug as of now. But now we have got the big
That's in
good.
hormone positive. That's in hormone positive only. Yeah.
Oh, okay. Okay, you're asking in the HER2 positive
This is the
subset.
TDXD trial. Yeah, the Destiny 09.
Oh, I think the benefit is irrespective of PIK3CA, no?
Yeah,
So
I think it is irrespective of PIK3CA, but I think can you go back the slides once?
I think the benefit was irrespective of all the subsets. That is what
Yeah,
they are
it was
saying.
regardless. Yes, yes, it was regardless.
So I would not change my decision of PIK3CA and HER2 positive.
Okay, okay. Next slide.
Sorry, sir. This is Dr. Satya. Just want to make a
Yeah,
point.
yeah, doctor. Sir. Yeah, yeah, sure.
Sir, like we discussed that PIK3CA is not making a difference with TDXT. I
Hmm.
do understand it is not a general practice to do NGS upfront, but if let's say a patient comes to you with an upfront NGS with a PIK3CA because it is showing in
You're cut off, Dr. Satya. Can anybody hear me?
Yes, sir, you're audible.
Okay. Acha, Dr. Satya is cut off, I think.
Dr. Satya's
hello,
network.
hello, am I
Yeah,
audible?
yeah. Yes,
Yes,
now
sir.
you're audible.
Yes, sir. So my point was, if let's say in the first line setting, if we are getting an NGS report where there is PIK3CA mutation in the first line setting only, so does that make sense that if we can use DB 09 for those subset of patient versus we can reserve Cleopatra for the rest, like Chandrakant sir told?
So, Chandrakant, what would be
I
your
don't know. I don't
opinion
know.
on?
I really don't know. If there is PIK3CA, is Cleopatra followed by Patina is better or this better? I don't know. I don't know what to choose.
Yeah, it's very difficult
Yeah,
to have a clear cut answer on
difficult.
this.
Yeah.
Yeah. Next
But the
slide.
funda is, as Dr. Indranil and you also said, TDXT is
Next slide.
not easy to deliver for years together. That's the funda. So we want to use
Right.
TDXT
Yes. Yes.
judiciously. That is the argument.
Yes. It's a very toxic drug. I mean, we have all burnt our fingers in some form, some patients or the other. One of my patients had to get admitted with intractable nausea, vomiting, neutropenia, and gross liver dysfunction. I had to stop TDXT and switch to PERT2, TRUST2, and hormonal therapy for some time to control the disease. So that's the problem. Next slide. So coming to the hormone receptor part, Serena 6, again an interesting study, just like the PADA. So proactive monitoring of ctDNA based ESR. And if there is ESR mutation detected, then you switch to camizestrant versus you continue the same AI. Next slide. And it has shown a benefit. Obviously, you're proactively searching for the mutation and trying to run at pace with the cancer rather than waiting for the radiological progression. So next slide. Next slide. Go to the questions directly. Yeah. So Devopriyo, uh, is it prime time to monitor ctDNA based ESR mutation in your practice as of now? Would you consider it in any eligible patient?
So I'll probably still not consider it.
Acha.
Why? Because we are depending on something that is coming up in an NGS without any actual symptomatic or radiologic. So now these very agents are available at symptomatic or radiological progression as well. We have
Okay.
availability of these CSR1 active drugs which are active here. Unless we have that comparison, like we just described for the last PDXD situation, unless we also have PDXD second line data, unless we have that using before versus using later thing, then I'm not sure what is the advantage of, getting it early only to get a better CSR.
Okay. Dr. Satya, if we keep aside the Serena 6 as of now, your set of patients, you detect an ESR1 mutation. So what is your routine practice?
Sir, as of now, we have not been able to use this newer SERD inhibitors, but we generally
They are not available also, I guess.
yes.
None of them are available.
So,
Yes.
but we do not just change if there is no radiological progression, and we are only doing this NGS testing when there is a symptomatic or a radiological progression is happening. So
Right.
we are going to the standard second line therapies.
Right. Indranilda, is it practice changing for you?
So most of these agents are not available here, so
Yeah.
hardly it matters.
Okay. Right. So if the patient says that I can import any drug
Then
in
I
this
will do.
planet. Okay. Okay. Chandrakant.
So Serena 6 basic thing is like 40% patients did not go to the second line setting. Like there are good number of patients who do not go to the second line. So once there is a obvious radiological progression, they may not be eligible for endocrine therapy in second line. They may be in visceral crisis.
Yeah.
So for that reason, if you have access to certs, we should do a ctDNA monitoring of PIK3CA If you do that, you are able to pick the progression 6 months before the radiological progression, and then you can
Yeah.
improve PFS by 9 months. So this is practice changing, and once the oral certs are accessible, we should start monitoring ctDNA for ESR1 before radiological progression. And elacestrant is available like just like osimertinib, like both the original to import and also the Bangladesh one. So elacestrant is cheaper if you can explore it at a lesser dose.
Okay.
It is cheaper. It is something close to fulvestrant. So that is an option that
Hmm.
you can go
Hmm.
for.
You have the Emerald study, I think, also with the Legastrand.
Right.
But that was, I think, in radiological progression.
Yeah, correct.
That was in
Correct.
radiological,
But
right?
yeah,
Right.
I know, but you don't have chemosistant right now.
Yeah, yeah, of course.
So
No,
in the
my question
meantime,
is, so patient comes to you, ERPR positive, HER2 negative, has done the liquid biopsy and is ESR1 positive. क्या करोगे?
at
First line
least at
chemistry?
upfront.
Yeah.
Yeah, why not? I will use ESR. So there is a trial. Uh, the IV IV PIK3CA inhibitor, PAM inhibitor plus oral SERD, irrespective of the ESR1 in the first line. It has shown good benefit. Again, mature data is required. But if
Okay.
upfront ESR1, why not? I should use oral SERD.
I think there
1%.
was this study, no, the inavolisib plus palbo
Yeah,
plus AI in the
inavolisib
first
plus
line.
palbociclib. Yes. Inavo
Mm.
120.
Yeah, yeah. Okay. So next slide. Oh, so patient is PIK3CA positive, HER2 low at metastatic diagnosis. What will be your treatment choice? Tanmay, you can answer this. Target PIK3CA mutation first, treat with TDXD first, combine the two, or something else. Tanmay, are you there?
Yes, yes.
Huh.
So how will you choose to pick three positive with HER2 low at metastatic diagnosis?
Yes.
I will always target the pick three first. That is right, because it's a targetable mutation. That's the only thing. Although HER2 low is
Another
also
thing
a
is
target.
that HER2 low upfront, there is no trial as of now. It's only after either one line of endocrine therapy based on
Right,
the this thing, or 2 to 3 lines of in for all comers.
right. So I will
Hmm.
be targeting the pick three first. Although the pick three
Okay.
agents are not so great.
Okay. Next slide.
Gedatolisib is a PIK3 inhibitor, IV PIK3 inhibitor that has shown magic. Hazard ratio is 0.2. So try and
Okay.
get gedatolisib IV. That is the drug. It is a PAM
Okay.
inhibitor. It's not only PIK3, it is PIK3, AKT, mTOR. It's a
The
PAM
whole
pathway.
pathway, whole pathway. Right. Right. Right.
It's a bispecific. So if you can get hold of gedatolisib, it's very effective.
Okay. Next slide. So again, the tropion breast 02, dato DXD, again not available versus investigator's choice. Uh, so here some one thing we need to note that in the inclusion criteria, immunotherapy was not an option for the patients included in this trial. Not an option means, see, there are randomization which is based on the high and low CPS score. So if a CPS score is more than 10, in that patient, if immunotherapy is not an option, then that patient would be eligible. I am not sure why that patient won't be eligible for immunotherapy, maybe some autoimmune disease or anything. So, question to Indranilda, are you happy with the control arm of this trial? Or do you think that this they should have included only CPS less than 10 who are eligible for chemo and not the more than 10 one?
No, more than 10, if they're not eligible, then they should be included.
Okay. Acha, that way you were saying. Okay, okay. Next
Yeah,
slide.
so they
Mm,
don't have that option.
mhm. So clear cut PFS benefit, good favorable hazard ratio. Next slide. And also there was OS benefit. Next slide. And the response rates was also much higher, 62% versus 29%. So these drugs should come as the NACT in TNBC. Next slide. So, Indranil, starting with you, in PDL1 negative patients, obviously you would not consider immunotherapy. So it is largely chemotherapy for you,
Yeah,
if I'm right. And do you think for this trial would be practice changing for you?
yeah, definitely. It's a
Definitely.
practice change.
Okay, okay. Any experience about the adverse events of this drug? Have you used it in a trial
No,
or
no.
anything? Any? Okay, okay. Anybody was part of the DATO trial that was going on many
We
centers, I
yeah,
think?
we have used
Yeah,
that
yeah.
to DHT.
Yeah.
It's
So
a safe
please share your experience about the side
right.
effects.
It's a safe drug. The keratitis was the thing that we had to do off-the examination. It's a safe drug. We have used this,
Okay,
not a toxic drug like this one. I think one patient had grade 1 pneumonitis. Otherwise, it's
okay.
a safe drug, nothing to worry. Only this sacituzumab govitecan is also a good option in those
Mm-hmm.
patients who are not eligible for PD-1. So these patients, not an option means either they were IO exposed or they were not eligible for IO because the PDL1 less than 10. That is what it
Yeah,
meant. So if
yeah.
PDL1 CPS is more than 10, I think the keynote regimen is the way to go. Uh, Now, PDL1 less than 10, you have two options, Dato DXT and sacituzumab govitecan, both are not available. And more
Mm.
options are toripalimab. It is an option even in low CPS. So nobody discusses toripalimab as an option because the hazard ratio is better if the CPS is less. So
So
that we don't know.
toripalimab, can you just briefly tell about the trial? I'm not aware. So that's why I'm asking.
So first line TNBC toripalimab plus chemo, it works. Not in
It
zero,
was a
at least
phase 3 randomized trial?
phase 3 randomized trial. Yeah,
Okay, okay, okay.
yeah. So it did show an efficacy. I think CPS should be at least one. And that was the
Okay.
thing. People showed a benefit in it. And the multiple criticisms of the trial are there. You can use story. But for
Hmm.
discussion purposes, what we can keep is CPS more than 10, Pembro chemo, less than 10, two options, Dato DXT and sacituzumab govitecan. Both are good options. The hazard ratio is better for sacituzumab, but the problem with sacituzumab is the toxicity. The
Yeah.
neutropenia
Very
is a big
neutropenic. Yeah.
problem.
Yeah.
So to avoid the toxicity, people prefer Dato DXT over sacituzumab. That is the argument.
Okay. Fair enough. Next question. Next slide. So with that, I wish to conclude. Thank you all my panelists for the wonderful discussion. Over to the organizing team.
Thank you so much, sir, for making this panel discussion interactive and interesting. And I would like to thank all our panelists also for sharing their valuable perspectives. And now I would like to invite Dr. P. N. Mohapatra, sir, for his comments.
Yeah, I mean, actually, there are a lot of development is in breast cancer actually, and these are clinical trials. They will go to practice, and actually, uh, we have to seize the pros and cons of these trials, and have to decide actually. So, I think the meeting was excellent, and every speakers were very nice and on time, and Jaydev's moderation was excellent, and the panelists actually everybody gave their input very well. Think we'll have more data and this data drugs because a lot of deruxtecan is there, datopotamab is supposed to come, and something actually we can when I go into practice, and especially the residual disease, and where they are giving TDM on TDXT because the cycles are limited and better result. And mm, thank you.